Hello everybody, today we are going to talk about pulmonary embolism. Um, there are a lot of patients that we see with pulmonary embolism um, with different complications, as there are more patients with cancers, more surgeries like hip replacement, knee replacement, and recently with the COVID, there is a very sharp rise in these patients who have DVT and then they embolize and have large pulmonary embolism. The traditional treatment for these patients was anticoagulation and still remains the gold standard. They will be on anticoagulation, but in subset of patients they will not be able to tolerate the anticoagulation, or even if they are able to tolerate the anticoagulation, they might be too sick before that anticoagulation can kick in. So they might need some kind of a support or some kind of a mechanical thrombectomy or mechanical aspiration of these clots to stabilize these patients. So we will quickly review these. Um, some of you might be doing this procedure if you are interventional radiologist or interventional cardiologist, or you may be taking care of these patients, or if at least not, you might be making a decision either on the floor or in the emergency room as when you are taking care of this patient as to how you approach and treat these patients. So with that, we come on to what's the definition of a PE or a massive pulmonary embolism. Again, it is all clinical decision making. There might be patients who might not have that big of a clot, but they might be hemodynamically unstable, so that might constitute a massive PE for them. But here I had just listed what the definition of a massive PE in the textbook that you will find. So if there is a hemodynamic compromise, for example, their systolic blood pressure remains less than 90 millimeter of mercury, and it has to be more than like 15 or 20 minutes. It's not like a brief episodes of hypertension. Or if they are hypotensive and they are getting fluids and still not responding, or if they are hypotensive and are on inotropes or dobutamine, dopamine, that also constitute a hemodynamic compromise in these patients. Or if they are hypertensive to begin with and they have more than 40 millimeter of drop in their blood pressure, they're not feeling very well, and their blood pressure does not come up with the measures that you might be taking to stabilize these patients. And of course, if there is a massive PE or there are bilateral multiple PEs leading to hypoxia, decrease in oxygen saturation in these patients, and if that is refractory to oxygen that you are giving to these patients. So those are all the things that compromise their circulation as well as respiratory status. But again, as I said, it's mostly the clinical and varies from patient to patient. So when deciding when to put these patients on a list for some kind of a mechanical or a more invasive procedure to stabilize these patients, one of the decisions that you have to make is, okay, the patient is hemodynamically compromised. If the patient is severely hemodynamically compromised and you think they will not be able to make to the procedural room, of course these patients need intravenous TPA or thrombolysis with the massive doses of thrombolytic medications like TPA. But that comes with its own complication. But if you have patient who, after temporizing measures, is a little bit stable and you think that they can be a candidate for some kind of a advanced treatment, one of the decision making would be, do they have underlying RV strain, meaning that their RV is struggling. Of course, again, as I said, the most important will be clinical. If you think, oh, everything fits in together, the CT scan showing big clot, CT scan showing a dilated or blown out RV, that kind of tells you, okay, the patient is getting RV strain, the RV is struggling to push the blood into the lungs. There are other things that you can do. One of them is called a PAPI, PAPI, which is a PA systolic pressures minus PA diastolic pressures divided by the CVP. So I won't go into the semantic of this, what these numbers mean, how do you do that. Of course, it's kind of an invasive way once you have these measurements, but it can also decide how much of the RV strain is. Of course, this is when the patient has already got the right heart cath. So because you need to know the PA systolic and the PA diastolic. Or if you have these patients with elevated troponin, a mild elevation in troponin, meaning that the RV is under stress, you might not see a whole lot of the troponin elevation in these patients because, as we know, RV can dilate. It is a thin wall structure, so it can dilate and fail before releasing any troponin. The BNP can also help you guide in these patients. Somebody who's got a normal BNP and now they're having a BNP in 200 or 300 kind of tells you that the RV as well as the atria are stretched, leading to the elevated BNP. Again, last but not the least is your RV functions. So you can do a quick bedside echo, look at the RV. Either the RV will be hyperdynamic or it will be dilated. You can look at the interventricular septum. There might be a bowing of the septum or the shift of the septum. Kind of all these features telling you that the RV is under stress. And another crude way is the EKG. Might not be always the case, but you might see in these patients the RV strain. You can have right bundle branch block, or you can have the classic what we call a S1Q3T3 in the EKG, kind of telling you, okay, the patient might be having, it's very non-specific and you might not be seeing this on a lot of EKGs. So for those of you who might be performing these procedures, it's a venous stick, so less chances of bleeding and complication, but still they are there. You can gain access to the pulmonary artery through the SVC. So you can go either to the IJ, or most commonly we go through the femoral, just because if we are putting more bigger bore sheets, we can get that access quickly with an ultrasound guided probe. So there are two ways you can gain access to the pulmonary arteries. These are the pulmonary arteries. It's a clot here. One is just to have the typical classic, as we call about a swan. You can put a swan in there and that will go up into the right atrium and then into the right ventricle and into the pulmonary artery. And then you can exchange this swan with a stiff wire. It can be a Rosen wire or any other wire that you might prefer. And then over that you can put these devices that we will be talking about. Oftentimes we have come across that might not be able to put this swan into the PA. And the reason I would probably tell you is, of course, if you are coming from the femoral, you have to manipulate the swan to go into the pulmonary artery. There will be some patients who will have large clot burden, or their RV will be failing. So as we know that the swan has to float in the blood to go into the pulmonary artery. I have taken care of a few patients where the RV functions are very low, or the clot is so big there is hardly anything going into from the RV into the pulmonary artery. In one patient, the patient was on ECMO. So imagine the patient is already on ECMO or an extracorporeal support. There is hardly anything flowing from the right ventricle into the pulmonary arteries to get your balloon, the swan balloon, to kind of float into that direction, and it is just gonna keep curling into the RV. In that situation, there is one trick, and that is a pigtail catheter. So this is a pigtail catheter. You can use a 5 French or a 6 French pigtail catheter, and it will help you. It will bail you out when you are doing these procedures. Even regular right heart cath, if you have problem getting your swan into the pulmonary artery and it's just looping into the right atrium, which might be huge, with patients who have pulmonary hypertension, this one small trick might help you, and this is by doing with the pigtail catheter. So if you look at the pigtail catheter, it's got a curvature here, and that will help you getting this into the RV and then into the pulmonary artery. And just by design, if you see that the the pigtail is curved, it's not pointed like a multi-purpose catheter or some other catheters. It is less traumatic. So it is less traumatic, and the curvature is designed in a way that it can help you gain access to the pulmonary artery. So let me show you how it will look like in the body when you are trying to get that the pigtail into the pulmonary artery. So as we saw, the curvature of the pigtail is just like it goes across the tricuspid valve and into the LV, and then when you kind of rotate it, once you have crossed the tricuspid valve, if you rotate it counter or clockwise, it will just quickly go across the pulmonic valve into the pulmonary artery. A very nice handy trick that might help you when you are doing these procedures, and I have found it very useful in some patients. So that with that we come to what are the things that we can do to these for these patients to help them kind of get them through this acute decompensated phase. One of them is recently been done a lot is the ecos, is the least of the invasive of these procedures. It's basically not a mechanical thrombectomy, but I just put it there for the sake of completion. It is these is it's for these patients, for those patients who you will be putting them on anticoagulation, but they are a little bit sick. They might have submassive PE, and they might have some contraindications to massive doses of TPA. So if they have some contraindication that they cannot get big amount of TPA dose, and they are in between where you don't want to just keep them on heparin thinking that they might decompensate, or they have RV strain, it's a nice catheter device. So basically, if you look at the chest x-ray, you might see on some of the pictures, the chest x-ray, you will see these two catheters with beaded appearance, just like a tentacles. You will see two tentacles, kind of, if it is a bilateral ecos catheter and you look at the x-ray, you might see that it's just like a tentacle of an insect kind of going around the lungs and with dots in the middle. So how does it look like? This is the pulmonary artery here. You have clot here, and then you place these catheters, if you have bilateral PE, across in both pulmonary arteries. And these yellow lines, as I've listed, are the ultrasonic waves. So the idea is, and again, there will be more data, there will be more studies to kind of prove if it is truly helpful or not, but this is the best we have so far, is that the idea is the ultrasonic waves that go across from these catheter make the clot a little more fragile, so that the TPA can go locally or infuse locally into the clot. Again, as I said, in 5, 10, 15 years, we might come up with a study saying, okay, this was not of any benefit, but so far the data has been very encouraging, and a lot of centers are doing it. So the ultrasonic waves make the clot a little fragile, and then the TPA infuses into the clot. You can run the TPA for 2, 4, 6, 8, or 12 hours. Initially, when they started, it was like 12 hours. And now some centers are doing even like 2 hours of TPA infusion. And then you take these catheters out, they take the sheath out, and then keep the patient on anticoagulation like heparin, and then switch them to the NOACs like Xarelto or Eliquis. Another nice device is a penumbra, which is an aspiration system. Basically, the idea is a mechanical aspiration. There is a device with a suction pump which sucks the blood along with the clot. And again, as I said, the same way you gain access to the pulmonary artery by doing a right heart cath or with a pigtail catheter, put the wire and then you put this catheter over the wire, and then if you reach the clot, you can do a pulmonary angiogram to see where the clot is, and then once you turn on the device, it sucks the blood along with the clot. This has a nice kind of a small wire that comes out of it and a bulb attached to it here, and this is to make sure that when the clot goes into the catheter, it might occlude it. So moving this bulb like bead up in and out of the catheter will help kind of break the clot, and then the device can suction that clot, and here it will suck the blood, filter it, and you can take that clot out to see how much of the clot is aspirated. It's a small bore catheter, so there is a less loss of blood. Another nice device is called the Inari. Again, it's a little bigger device where you have this suction catheter. Again, you gain access to the pulmonary artery by putting the wire in the pulmonary arteries. It's got a big syringe attached to the other end, and with a negative suction, you put the catheter right at the clot site, and then you aspirate with that syringe. As I said, it's a bigger device, so there is more blood loss. They might need blood transfusion. Similarly, with this Inari catheter, if the clot is organized, it's not coming back into the catheter, they have come up with another device that you can put through the same catheter over the wire, and it's got like these discs. They look more like an Amplatz device. So these are like spring discs. So when you go across the clot, they are closed, and once you open or unsheath these discs, they open up in the pulmonary artery, and when you pull these discs back, they kind of trap the clot and go into the catheter. There are a lot of videos on the internet that you can see to clearly how the animation works for these. And last but not the least is the angiovac. This has been there for a long time. The downside of this is it's a large bore catheter and a device. You need to establish an extracorporeal circuit where you suck the blood out from one venous access site, and then you re-deliver the blood into the other venous site. The reason for that is, as I said, it's a large bore catheter. It sucks the clot out, but at the same time it sucks a lot of blood, and you want to make sure that you filter that blood and then put it back into the patient. It comes handy in patients who have large clots. They are not anticoagulation candidate. They are hemodynamically unstable. If they have large clots in the RV or the right atrium, that might be too big for any of our other devices, you can use the angiovac. I hope this was helpful. Let me know any feedback. I'd be happy to kind of discuss this.